It is highly probable and possible that you might have already heard about this molecule Clascoterone. It's in the news for its usage in androgenetic alopecia. So in this video we are going to discuss about this very molecule, and along with that we are going to also say about minoxidil and finasteride. What is the relationship between these molecules for androgenetic alopecia? Hello dear students, myself Dr. Maddineni Srinivas. Welcome to my YouTube channel. If you are not yet subscribed, please do consider subscribing so that you are going to get all the latest news related to dermatology and latest updates, especially like this kind of medications which come once in few decades. Right? So this is basically an androgen receptor blocker which has been in the trials. It's not yet approved, it has been in the trials, and the company Cosmo is going for probably FDA submission for registration purposes to get the approval, which might take 2027. Maybe by that time, if the approval is going to happen, this medication will come to the markets. So this is going to be a topical agent which is going to act as an androgen receptor blocker used in androgenetic alopecia. If you remember, we have already made a video on this very medication with the acne in the form of Winlevi, but the concentration was 1%. Okay, it is already available commercially for the acne treatment, right? And yes, the medication is new, so probably if you are in your first year or your second year of dermatology residency, probably by the final year when you write the theory exams, this is going to be one of the important topics for the fourth paper, which in which latest updates are going to be discussed, and they are going to be asked in the theory examination. So listen to this till the end, you are going to get a clear cut idea. So to understand this molecule, you should know what is the pathophysiology of the androgenetic alopecia. We are going to see that briefly, and definitely mechanism of action I will explain you. So summary, we will see what is the trial summary and what is the dosage, what is the efficacy, what are the limitations, what are the advantages. Okay, and also current EJ therapies also you'll get an idea, because we are going to discuss this in relationship to the other molecules, right? So to give the intro, remember this is a steroidal androgen receptor blocker which is available topically, right? So this steroidal component is important because the limitations, disadvantages in that we are going to discuss what is the significance of this, right? And it's as I've already told you, it's already approved for acne in the form of 1% cream, which is Winlevi, right? And higher strength is now being used for the scalp solution in the trials. The marketed name is Breezula, right? And the selling point for this agent, topical agent for androgenetic alopecia, is that it will act locally and it's going to be metabolized very rapidly into a inactive form which is called as cortisol. So what the company claims, what the studies claim is that it is not going to be absorbed systemically and it's only going to be local in action. So that is a plus point, that is a good news for those who are having androgenetic alopecia, right? So the pathophysiology of androgenetic alopecia, what is exactly happening in androgenetic alopecia patients? There's going to be a DHT driven miniaturization. What is DHT? Dihydrotestosterone. So this DHT, if you remember, the testosterone which is present in the bloodstream under the 5 alpha reductase, it's going to be converted into dihydrotestosterone. And in the androgenetic alopecia patients, what happens is this DHT, it's going to cause the miniaturization of the hair follicle, and also it is going to act and it is going to prolong the telogen phase while shortening the anagen phase. And if you remember, anagen phase is the phase where the length of the hair follicles is going to be decided, and anagen phase usually it will stay for a period of 3 years, whereas in androgenetic alopecia patients, because of the DHT, it's going to reduce very drastically. So there is going to be hair fall, right? And this is basically the problem in androgenetic alopecia. And also there is going to be decrease in the hair shaft density and diameter. So the size of the hair, not only the lengthwise but also in thickness also is going to reduce under the DHT activity, right? Additional targeting molecules, finasteride and minoxidil, what was their action? So they are, the first one is 5-alpha reductase inhibitor, which is going to reduce the DHT levels at the dermal papillary cell level and also in the bloodstream, because finasteride is a oral medication. And what is the mechanism of minoxidil? It is basically a follicular stimulant. It is going to cause vasodilatation, thereby increasing and causing stimulatory effects on the hair follicles, right? And this is a new target which is going to be local androgen receptor antagonist. This is a good news because this is not going to reduce overall DHT in the blood, so thereby it's not going to cause the hormone level imbalance in the blood. It is only going to act at the follicle level, clascoterone. That is the beauty of this topical medication, right? And so what is the affinity of the DHT? It is going to be 2 to 10 times more potent when compared to the testosterone. That's why in the bloodstream testosterone is getting converted into DHT, and DHT is having more possibility of causing this miniaturization and also causing the prolonged telogen phase and shortening the anagen phase, right? So this is the pictographic representation of the testosterone which is present in the blood getting converted under the influence of alpha reductase into dihydrotestosterone, and this dihydrotestosterone is going to act at the dermal papillary level of the hair follicle, thereby producing this miniaturization of the hair follicle. So that is a pathophysiology of androgenetic alopecia. Now coming to the mechanism of action of the Clascoterone. So we have already seen that it is an antagonist at the androgen receptor level. So basically what it is going to cause in the acne. So in acne it is going to block the androgen receptor, same mechanism. Thereby it is going to cause the reduction in the sebum, and also it will reduce the inflammation. Thereby acne lesions are going to get improved. So in androgenetic alopecia, so like we have already told, it's going to block at the scalp dermal papillary cell levels the androgen receptors. Thereby it is going to reduce the prostaglandin D2 and also interleukin 6, and thereby it is going to also reduce the possibility of miniaturization of the hair follicle under the influence of the DHT signal, right? So what are the formulations which are available in acne? So I have already told you it's available as 1% cream, and its application is BD for the acne prone areas over the face. So coming to androgenetic alopecia, the formulation here is in the Breezula investigational level, it is 5% and 7.4% for the scalp application. So it is either applied once daily or also BD application is also there. Okay. So it is now studied in the men for androgenetic alopecia. Female studies are not yet done, so they are awaited. And also remember, it's not yet FDA approved. It maybe it will go for the approval next year, and it will be in the market in 2027, right? So the studies are basically with the help of the molecule and the vehicle. Both are compared with double-blinded randomized controlled trials, and you can see here the duration is up to 12 months the study was done. And what is the end point? The end point is the change in the targeted area hair count. So this is the end point, the improvement in the targeted area hair count, that is in a given area. In a given area we are going to see this study, this TAHC study already has been done, and it has been approved for minoxidil and finasteride. So for approval of minoxidil and finasteride also, this was the same pattern which was followed to observe the total targeted area hair count and its improvement when compared to the vehicle. So same studies are being done here also, and there is absolute standardization without any bias. The results are going to come out in the phase 3 and also phase 4 trials, right? Next we are going to see this thing. Yeah. So with the different concentration, what is the improvement? With 7.5% Clascoterone BD application, it was observed that when compared to the baseline, there is plus 20 hairs per square centimeter which are being developed when compared to the baseline level. And if you see, there is plus 14 hairs per square centimeter when compared to the vehicle. So definitely there is some kind of improvement which is seen with the medication Clascoterone, right? And when once application was done with the same 7.5%, it was observed that it was less when compared to the BD. The improvement was a little bit less or inferior when compared to the BD application, right? So interpret modest but significant regrowth is seen, especially the early onset moderate type of androgenetic alopecia. Remember, the medication usage is for early androgenetic alopecia, but not the late stages of androgenetic alopecia, where maybe probably most likely the hair transplantation is only going to be the best treatment option which could be available for the patients. So these are the studies, Scalp 1, Scalp 2, where more than 1400 men were recruited and a study was done. And yes, it was this thing, 5% solution, and this is the phase 3 trial. So in phase 3 trials, the 5% solution is being studied, right? And yes, the improvement in the TAHC is again the criteria to be fulfilled. So it was observed that in the phase 3 trials, the improvement in one study was up to 539% relative improvement when compared to the placebo, and in another study it was observed 168% relative improvement when compared to the placebo. So overall key factor which we have to remember is there is 5.39 times more improvement when compared to the placebo, right? But it is not that 5.39% times of the total hair. That is, if 100 hairs are there, it's not that 500 hairs have been developed. No, it is not the way you have to understand the study. When compared to the placebo, there has been 5.39 times better outcome when compared to the placebo in the Clascoterone group, right? So safety profile, so adverse events are more or less the same as the placebo. So no major systemic hormone related side effects. If you remember, we have told that it's a steroidal androgen receptor blocker, topical, right? So no such systemic hormone related side effects are seen. That is the most important one, and mostly this local application side effects which the patients experience, right? But nevertheless, post marketing you are going to get any other kind of adverse effects if at all they are there for this medication. So locally it is going to produce the erythema pruritus, more like what steroidal medications can produce, a tingling sensation, irritation, burning, stinging sensation, right? Extrapolate cautiously to higher strength of scalp usage in the androgenetic alopecia. So these all adverse effects were related to the lower concentration 1% Clascoterone over the face for acne. So we have to carefully extrapolate these adverse effects to the scalp, where the body surface area is going to be relatively more when compared to the face, and also the concentration is also a little bit higher. So we have to carefully see and observe and monitor the patients for any probable adverse effects in the future when this gets approved, right? And most important, like I have told you, because it's steroidal again, so HPA axis suppression, this is a major concern, and studies mainly focused to see whether there is any hypothalamo pituitary adrenal axis suppression. But it was observed that if at all the suppression happened, it was very mild, and also good news is it is asymptomatic and it is reversible, right? It is observed after 2 weeks of maximum use exposure. What is maximum use exposure is the it was done that body surface area maximum whatever can be applied over the scalp, it was applied, and maximum concentration 7.5%, everything was done, and after that it was observed that the effect on HP axis is very very minimal. So if at all it may happen, then what is the reason, what could be the risk factors? So risk is going to increase in the case of children, right, and adolescents, and also if they are applying over the large body surface area, and if the occlusion is done, and also prolonged use is done, and also extremes of the age in the elderly also, the risk of systemic absorption may increase. So we have to be careful and we have to monitor them, but for time being it is also mentioned that it is better avoided in this age group. So we will see that in the next slides. And also hyperkalemia was also observed, and there was no such increase in the potassium levels in the blood. So no routine potassium monitoring is required in the patients who are going to be started on topical Clascoterone for androgenetic alopecia. So absolute contraindication is the hypersensitivity to the Clascoterone. And coming to the safety, which is not yet established, like we have told already, children less than 12 years and adults more than 65 years, we have not yet used, so we don't know what could be the outcome and the adverse effects in this age group, and also pregnancy and breastfeeding. So we better avoid in this, like as we do it in for most. So coming to the dosing and the administration, it is available as 1% cream for acne, and the trials it is 7.5% or 5%. Probably we are going to say the 5% as once daily application over the thinned areas, and we can expect the response from anywhere 3 to 6 months, and it's going to be maximum for a period of 1 year. So that is going to be what is the observation in the future. Most likely we are going to see that. So what are the advantages of Clascoterone? This is more important. It is local androgen receptor blocker. So there is going to be minimal systemic exposure, and the problem with the other oral medication, that is finasteride, all of it's going to cause a sexual dysfunction, and the potentially lower risk of sexual side effects is going to be very good news for the androgenetic alopecia affected patients when compared to the finasteride, right? And it is a non-invasive topical formulation. It's good for young and those who don't want any kind of a risk, even if it is very minimal, with oral dihydrotestosterone reducing medication finasteride, right? And also it can be used in combination. We can also use with the minoxidil or the low dose oral finasteride if the patient is okay with finasteride, right? And it was observed in the acne patients according to the acne data. So lower discontinuation rates were seen with the Clascoterone when compared to topical retinoids. Topical retinoids probably they are also used in the acne treatment, but because they can produce irritation of the skin, dryness, so maybe patients prefer the usage of Clascoterone over retinoids in the acne, right? Yeah, we may also expect that patients may like the usage of Clascoterone when compared to even minoxidil and the oral finasteride, right? So what are the limitations and disadvantages? This is very important. It's definitely going to be very expensive medication when it comes to the market, right? So it requires refrigeration until opening in the acne. Maybe that is going to be the same case with the preparation for hair application. So it is a topical androgen receptor blocker. So it may be used best for early and moderate androgenetic alopecia. May not have a very good role in the late and a little bit mild or severe forms of androgenetic alopecia, right? And also long-term data of decades of continuous usage which are there for minoxidil and finasteride are lacking in this, because obviously this is a new medication for new indication. Possible steroidal local side effects may be occurring with chronic usage. We have to see this in the phase 4 clinical trials. So when compared to the existing androgenetic alopecia treatment, so you can see minoxidil, it's going to cause anagen promotion and it's going to also cause vasodilatation. It's a topical medication. Initially there could be a shedding phase and also irritation with minoxidil in few patients. Finasteride, so it's an oral and it's having erectile dysfunction as an important side effect, and also teratogenicity. That's why it is absolutely contraindicated in the females, right? So Clascoterone, yeah, this is a medication. Local irritation could be a possible problem. Cost is definitely going to be a problem. Local androgen receptor antagonism is the advantage of this medication, right? So we have seen all this. Okay, if approved, yeah, this is important. If approved, this is going to be the first new androgenetic alopecia drug class which has been produced or developed over decades of the old medications, minoxidil and finasteride. This is going to be a fresh molecule for androgenetic alopecia, and also first topical androgen receptor antagonist for androgenetic alopecia. And you can consider this as a topical finasteride application over the scalp instead of taking orally. You can consider this analogous to topical finasteride, but the mechanism is different. Finasteride is going to block the alpha erectus enzyme, and this is going to directly attach to the receptor level, and it's going to block the activity of the dihydrotestosterone. So who are the ideal candidates? Like we have already told, young men with early androgenetic alopecia and those who are reluctant to take finasteride because of the adverse effects, and patients who had prior sexual side effects on systemic anti-androgens. And you can use it as a add-on agent with minoxidil also, right? or it can be also given as a monotherapy also. So counseling is very important for the realistic expectations. They have to, understand that hair has been gone, but it will take some time for it to be restored, and also it will be, application has to be in a chronic way because it's a chronic disease. So we have to make the patient to understand the reality of the androgenetic alopecia. And also, long term adherence is also one of the challenging points of this topical preparations. So now coming to the exam oriented knowledge or points which you have to know for dermatology residents. So it is a topical steroidal androgen receptor antagonist, and the indications for acne vulgaris 1% cream, and for androgenetic alopecia it is 5 to 7%. We have to await what percentage it will come. Maybe it will come as a different percentage, like just like minoxidil is available as 2% and 5%. We have to see. So in the sebosides is going to reduce the sebum, which is why it is used in the acne, and dermal papillary cells level it will attach itself onto the receptors, and it's going to block the DHT action. Right, so these we have already seen. So take home message, it's a novel topical androgen receptor antagonist. By blocking dihydrotestosterone, it is going to cause the reduction of the miniaturization, and also it will reduce the shortening of the anagen. So thereby it will promote the hair growth, and thereby it will promote the longevity of the anagen hair follicles. So clinically meaningful hair count gains were noted when compared to placebo. So it's a very good news. It's awaiting the regulatory approval, the FDA approval. And these are the differences between the finasteride and Clascoterone. So I have kept this just for the reference purposes, so you can read it. You can pause the video and read it. So the bold are the ones which are very important. So this is just a slide which is showing you all the molecules and their mechanism of action. So D testosterone is going to get converted to dihydrotestosterone, and this dihydrotestosterone it's going to act at this level, at the papillary cell level, and thereby it is going to cause this miniaturization of the hair follicle. So the medications which you are going to use, that is alpha reductase inhibitor, the finasteride, dutasteride, they are going to prevent this conversion of testosterone into dihydrotestosterone. Thereby the activity is going to reduce, so miniaturization is going to reduce, right? And whereas here we have this minoxidil which is going to act as a stimulant, which is by the way of the vasodilatation, it's going to increase the blood flow, and it will prolong the growth phase, right? So now here comes the medication which is the Clascoterone, which is going to act at the androgen receptor level, and thereby it is going to block the receptor for DHT. And the similar mechanism is also there in spironolactone, right? They physically block the DHT from binding to it, the receptor. Thereby there is not going to be this hair follicle miniaturization. So thereby the anagen hairs are going to become lengthened, and also the miniaturization is going to be avoided. This is all about the Clascoterone. I hope this video was helpful. Thank you so much for watching this video till this point. And if you have really liked this video, please do consider subscribing this channel after you like this video. Okay, in the comment section you can write down any doubts, whatever you are having related to this molecule or androgenetic alopecia.